Hey everyone, it's Dr. Arnold. I'm excited to announce a new segment that will be coming to the podcast, and that is the Mailbag. If you have questions about COVID-19, latest technologies and procedures, and other services provided at UnityPoint Health, Cedar Rapids, or even other general medical topics, you can now submit those questions to me, and they may be answered on the podcast. To submit your questions, go to unitypoint.org/mailbag. That's unitypoint.org/mailbag, MAILBAG. Please note that the mailbag is certainly not an alternative to a medical appointment. Any questions about personal symptoms or conditions need to be directed to your primary care provider or an urgent care. And as always, in the case of an emergency, dial 911 or present to the nearest emergency room. Once again, you can submit your questions to me at unitypoint.org/mailbag. That's unitypoint.org/mailbag, MAILBAG. I look forward to hearing from you, our amazing listeners. This is LiveWell Talk on Skilled Nursing Part 2. I'm Dr. Dustin Arnold, Chief Medical Officer at UnityPoint Health St. Luke's Hospital. With recent rise in hospitalizations, geriatric patients are impacted by COVID-19 as well as other medical conditions that perhaps could have been delayed during the lockdowns of 2020. Return to the podcast today to discuss skilled nursing as well as kind of the impact that hospitalizations have on our geriatric patients is Dr. Clete Younger, who's Medical Director of St. Luke's Living Center. And for the first time on the podcast is Lindsay Glynn, Executive Director of AbbeHealth Aging Services. Today we'll discuss how hospitalization may impact geriatric patients, cognitive health, and how we can be supportive and improved upon with skilled care nursing. We'll discuss resources of aging services. Clete, Lindsay, welcome.
Thank you.
Thanks so much.
Okay, first question, Lindsay, do you know why it's called AbbeHealth?
Well, it used to be Abby Inc., but, a lot of our focus historically has been on mental health. And as we started expanding our services, we focus on so much more than just mental health. Aging Services is an affiliate of AbbeHealth, and we focus on older adulthood and making sure that people have the services they need to remain in their home for as long as possible, because we know that that's where people want to age, and mental health and aging are two very huge components to everyone's health. So
I actually was be a little bit more specific why it's called Abby. Do you know the story behind that?
That's fun because I don't know specifically the Abby component of that. No.
Well, the first director wanted it to be early in the yellow pages, from an alphabetical standpoint. And he lived off Mount Vernon Road, and that Abbey Creek is there, and that's how it became AbbeHealth. That's a
He
true
wanted it in the front of the phone book.
Yeah, Jeff Wilhorn told me that story. And he was there in the beginning, so he should know.
I wish I was that creative.
Yeah, I can only repeat these stories. I'm not smart enough to come up with them. But, well, I think that's nice to explain aging health services, because I personally have never really understood exactly what their role is. And that I will kind of develop more upon that during this conversation today with Dr. Younger. Clete, what, or either one of you, let's start with Dr. Younger. What impact does being hospitalized have on a geriatric patient? Not just only their, whatever the medical condition was, pneumonia, heart failure, etc., hip fracture, but just on their overall well-being from a psychological standpoint, a functional standpoint. What are the detriments to simply being hospitalized, and why? And hence, it's a good reason not to be hospitalized.
I think sometimes what we see is that a hospitalization, it exposes frailty. So it'll expose something that's there before that you may not have been aware of. And, we all want to be optimistic when we talk about our function and what we can do. But sometimes a hospitalization will expose what someone's frailties are, and that will show to themselves or to their family or to the community, oh, we have deficits in this area, or this is a limitation in function that a patient may be experiencing. Unfortunately, sometimes too, we see a hospitalization as a threshold. So where somebody may have a gradual decline in function, a hospitalization can be a drastic decline in function. Sometimes that function will come back, and sometimes it won't. So sometimes patients will have a complete shift in their functional level associated with certain types of hospitalizations that then requires higher levels of care going forward.
Lindsay, what's been your experience with the patients that you support, and how a hospitalization may influence their functional capacity and their ability to return home.
Yeah, so we see that quite a lot. Really, the amount of care after their hospitalization does rise, right? They need more supports as they're transitioning out of the hospital, and there are a variety of reasons for that. Sometimes it's restricted mobility in the hospital, continence, medication issues, lots of reasons for that, and some, like Dr. Younger said, sometimes it's something that we can really help with. Sometimes it's long-term effects of those hospitalizations, especially if they're frequent and people are returning to the hospital often. And so a lot of attention and focus for us is on prevention and wellness as well.
Well, I'll tell a quick story. I can remember this patient I had when I previously practiced in Grinnell, so in the late 90s. Nice old lady, nice little old lady, cute, the stereotype of the cute little old lady lived by herself, would come to the clinic, and it would be the same routine every 6 months. She would come, introduce herself to the staff, they'd take her blood pressure, there'd be exchange. I would see her, talk to her, she'd be perhaps slightly ingratiating in her answers, give me non-specific, but yet correct answers. Then she got admitted for pneumonia once, and we're around her for 24/7. And she has rather significant dementia, and we took her out of her routine, and it became amplified. Clete, can you talk to something along those lines? Is it? I mean, the hospitalization doesn't cause the dementia, but perhaps it reveals it. Is that a fair observation?
Yeah, so what you have to think about is when you're at home. So if you're at home in your chair in your house, you know where your clock is. You have this object here. You're used to your food being this way. And because people develop these routines, they don't have to think about that as much. So if I'm at home, I know where the clock is, and I don't have to think about where is the clock, what time is it, when I'm going to eat, how I'm going to eat. So when you go to a hospital setting, that clock's in a different spot. The food's coming from a different person. Furniture's in a different location. So all of a sudden, you have to start using your cognitive ability to try to reconcile all this information. And in somebody who has a diminished cognitive capacity, if now they have to worry about what time it is, where their food is, and where their clothes are, they don't then have the capacity to have higher order thinking about answering complex questions or making complex medical decisions because they're so absorbed in just the simple things of those little details that we take for granted when we're in our home setting. All of that goes away when you put somebody in an unfamiliar situation.
And I think your comment earlier, we'd infer that you may not get that back.
Mm-hmm. That's possible, especially if somebody then requires some other thing. So if a hospitalization results in a transition to living somewhere different, like senior living or assisted living, it's going to take a while to build that back up, that confidence of where you're at. Or if it's a new medical problem that all of a sudden requires a lot of extra thought. So if you have to take a new medication, there's a new management strategy. Or is it a fracture that's led to a pain syndrome? So part of your cognitive ability is being absorbed by, dealing with the pain you're experiencing. It's going to take away your ability to have other cognitive processes function as well.
I don't recall discussing this with you, Clete, on the last podcast, but I think now would be a nice point for you to illustrate what sundowning is, because I think that term is sometimes misused, but most of the time accurate. But could you give us what sundowning is?
So the
I
term
think it fits into the timeline you're talking here.
Yeah, the term usually relates to the time of day for when a patient sometimes can have increased issues with cognition, or sometimes we see behaviors. When we wake up in the morning, we're usually a little bit more energetic. And what happens is people tend to fatigue throughout the day. So as you go throughout the day, your brain gets more fatigued, your body gets more fatigued. And there's a phenomenon where we will see in the hospital setting or in our skilled settings where patients somewhere between the time of like 2 o'clock and like 8 o'clock at night will all of a sudden become more confused. And confusion sometimes can be met with a response of people get more withdrawn. They don't want to do things. They seem less responsive, or sometimes it can cause agitation or aggressive behavior. So when we typically hear sundowning in a nursing home, they're usually referencing a patient who gets agitated or aggressive in the afternoon around dinner time. And part of that has to do with just the fatigue of the day, trying to keep up with all the demands that they're having cognitively in an unfamiliar place. And sometimes it's pain because they've been more active during the day doing therapy and things like that. And then they get more painful, and that can cause some agitation throughout the day. And there's just kind of a general increase in energy as people go throughout the day in a facility that sometimes leads to that behavior.
Yeah, my daughters say that I have Bedtimer Syndrome, where I just get grumpy about bedtime. And so it's a related condition, perhaps. I don't know. I hope not. But uh, so it's not related to the circadian rhythm of the day necessarily. It's really the activities that preceded the behavior.
It depends. So circadian rhythm is interesting. So there's certain disease processes where we know you lose circadian rhythm. A very common one is Parkinson's disease.
Yep.
So Parkinson's patients tend to not sleep well because a part of their brain that's affected by the disease process is part of their circadian rhythm. In certain dementias, we'll see the part of the brain affected that has to do with that sleep-wake cycle. And that sleep-wake cycle goes away. So then people either sleep poorly or they sleep at odd times that don't match with our traditional timing with therapy or with meals. And that can cause complications with that.
Lindsay, it is the role that aging services have or provides, let me say, is there things that can be done to determine this cognitive decline ahead of time? I mean, rather than it being a revealing event at the hospital or with hospitalization and subsequent sundowning or agitation like Dr. Younger's describing.
Yeah, absolutely. I think a lot of people can become anxious as they get older regarding, is this normal aging, or am I experiencing something here? And I think, having that self-awareness and thinking about how you and your loved ones are doing and knowing what's normal for you is good, and having open conversations with your family docs about those concerns are really important. We do have the ability to assess cognition before hospitalization to really see, and it's about looking at whether or not it's having an impact on your day-to-day life. Can be a major factor in really being able to assess that. People are always forgetful, right? And figuring out a way to determine whether that's normal aging or normal forgetfulness is an interesting conversation. And having those conversations with professionals and doctors are important because it can be nerve-wracking.
And yeah, that 23andMe and these genetic tests. They said, well, we can find out whether or not someone might be more likely to have Alzheimer's. I'm like, yeah, that'd be great. And the first time you forget your keys, you're like, oh, starting. I mean, so that I don't know how great that would be. But that being said, addressing these cognitive dysfunction ahead of time it is important. I don't want to make light of that, but is how do I try to say this? Nobody goes to rehab halfway to rock bottom, right? You don't wake up and say, man, I'm halfway to losing my job today. I think I'm going to, go seek counseling and quit drinking and whatever ill that is affecting me. So sometimes patients and families, to get a buy-in to this, recognizing this cognitive decline, it does take a significant hospitalization to reveal this. So how do you build that rapport with the family to explain to them why their loved one, or even explain to the patient themselves, can't go back to living alone?
Mm-hmm.
So I think there's a couple of things to think about. So when we talk about this, recognizing it, there is a high sensitivity for cognitive disorders if a family member says, my parent or grandparent is forgetful. If you hear that term, those patients can be diagnosed with dementia greater than 80% of the time if you do cognitive testing. So I think one thing is that people, sometimes family members will acknowledge it, but if you don't ask the right questions, sometimes you can't get that out of them. Like they may not tell you somebody's forgetful, but if you ask a family member, hey, is your parent forgetful? If their response is yes, you need to be very on guard for a diagnosable dementia at that point. And it doesn't mean somebody can't be at home necessarily, because there's different varying levels of dementia, but people do have some realization that their parent or their grandparent or a loved one may have some deficits. Now, we are social beings, so we interact very socially in conversation, particularly with family. And there are some patients with dementia you could have a conversation with for 2 hours. They could have moderate advanced dementia, and you would never know because they're so conversational and they read off of physical cues and and verbal cues that they're able to converse with you. But if you ask them what time it is or to add two numbers together, they may completely fail that question because the part of their brain that they can talk to you socially works great. But another part of their brain, which is, do I remember to turn the stove off, or can I drive safely in a car? There may be significant deficits there. So it does take some time to build rapport with families, but I think explaining some of those things that they start to acknowledge, oh yeah, they forget this stuff, and ask them, have they done something functionally wrong? Oh yeah, they had this functional thing go wrong. And it helps people start to kind of realize the picture of, oh, there are deficits there, because sometimes the social interactions can really trick you.
Yeah, I've had, you have the daughter that lives out of state, talks to mom maybe once or twice a week, it, and then she comes home for the holidays, says, "Oh my gosh, mom's demented." But then you have the daughter that lives in town that says, "No, mom's been forgetful for a long time." It's just that like you said, that ingratiating personality that, like I always say, you ask the patient, "How was breakfast?" "It was good." "What did you have?" "Oh, the usual." And they might not even had breakfast, but if you just had that snippet, you would believe that was something that they. Well, either one of you can answer this question. So we have, how do we determine whether or not someone's going to return home after skilled nursing that with a cognitive decline, or need to be in a memory unit?
So you want to go, Lindsay? You want me to go? Because I do a lot of discharges.
I think what's interesting is I think that we would have a couple of different perspectives on this. So I would
Well,
like to hear your perspective
Yeah.
first.
Let's hear them both.
So,
Yeah.
so what I often ask patients is, can you sleep? Can you get dressed? Can you go to the bathroom? Can you get food? Are you then able to call for help if you need it? Right? So it gets at these very fundamental things about being a human being: eating, going to the bathroom, getting dressed, taking care of yourself, and being safe. Can you do those things? Right? We have to start there. And if there's a deficit in one of those, then we have to find something to replace that. Then the next level of complexity is, do you have a medical condition that you then have to manage on your own? So do you have an unstable medical condition where if you're not able to take your medications effectively, are you going to get into trouble if you're not able to do that? So those are the two layers that I typically start with on, can you do this simple stuff? Can you do this complex stuff? Okay, if we can do both of those, we can start talking about being at home. But if there's a deficit in one of those and we don't have a solution for it that involves family or the patient doing it themselves, then we have to start looking at higher levels of care to supplement those deficits.
And is there, Lindsay, maybe you can answer this is there a gradation of levels of care that might be provided short of going to the nursing home or skilled care facility? I mean, is there stuff that we can do prior to that?
Yeah, absolutely. So there are absolutely differing levels of care that are options, and that's a great segue into the fact that that's great. We have medical professionals that assess whether or not somebody should be able to safely go home. And the thing that aging services often runs into is patients saying, we don't care, we're going home anyway, right? Like we just want to be home. And so we have people that are trying to live at home that are unsafe, but it's also their right and their choice to be at home. And so we're helping navigate, how do we keep them as safe as possible at home, right? And so there are varying levels of care, and it's all about building that rapport with people so that they know that you're here with them, by their side throughout this process, because there are options for them at home to help keep them more safe, working with physicians to really try and make sure that people are making the safest decision possible in that move.
Lindsay, how does one, let's say I have a parent, I'm concerned, and I think they might need some assistance. Can I just call Aging Services and say, help us?
Absolutely. Yeah, absolutely. So we do a lot of work to help prevent any safety issues ahead of time, and we can help after somebody is discharged from the hospital, from to skilled back to home, and work with a lot of social workers. They can just give us a call and talk about services that are available through Aging Services, but also other organizations as well. There are a lot of services and resources out there to help people remain in their home as long as possible after that discharge from the hospital to skilled to their home. All of
Yeah.
those levels of care that we're referring to, right?
I think if I could sum up this podcast to two things I want listeners to hear, that is, one is you're not alone in these decisions. There's highly trained professionals that are here to help you, and they will help you. And number two, that hospitalization, you may never get back to where you were prior to the hospitalization, and that's okay. Um, so I just, I don't want people to have unrealistic hope that grandma or your uncle is going to get back to where they were before, because they may not. And I think that's the important take home, that a significant hospitalization is a significant hospitalization. It's a life event. And sometimes it has ongoing ramifications or consequences, I should say. One thing that we wanted to touch on in this podcast was driving. And Clete, you and I have had this conversation before. I've had this conversation many times. I was even thinking about this podcast on the way to work today as I was driving. And I was thinking, sometimes it's easier to tell someone they have cancer than it is you can't drive anymore. So, Clete, how do you approach that? That's a tough one.
Yeah, so driving is that's people's freedom. That's their ability to go out and do things.
Yeah.
That's independence. And so, unlike a lot of things, when you start taking away somebody's freedom and independence, that's, as an American, that's very hard because we value that a lot. So if somebody chooses to not take a medication, or if they don't use their CPAP, the impact of that decision is on themselves. Right. And at some point we allow people to be autonomous. And if you don't want to take your medicine, there may be a consequence. I should explain to you what that is so you're prepared for that. But ultimately, if you choose not to do it, then that's your own decision. When you start to talk about driving, or this comes up sometimes with caregivers for patients with dementia, now your decisions can impact someone else. And one of the things we really get concerned about are decisions with driving, such as wrong way crashes. And these are the most significant, and what we worry about a lot with dementia. Because if you get into a wrong way crash, the fatality rate of those kind of accidents is significantly higher. It's not fender benders we're worried about. We're worried about somebody getting on the interstate going the wrong way, because the impact of that can be so significant. So what I often try to talk to family members about is, we need to acknowledge that this cognitive process may lead to somebody having a problem driving, or they're in my office because they had a car accident and the DOT made them come in. What I often tell families is, one, you don't want your family member's legacy at the end of their life to be that they killed a kid in a car accident. Nobody wants that as a legacy, right? And when you start to think of it in that terms, that changes people's perspective.
That's a
And they
great,
say,
that's a
I just
great
want to
tool.
drive.
That
Like,
is
well,
a
what if
great
you
tool.
killed a kid? Oh, I don't want to do that.
Yeah,
I'm like,
that's a great tool.
there you
That is
go.
great.
We need to think about how to make that happen so we don't have that. Then you have to make people not feel abandoned or on an island. If you tell them, hey, we're just going to take your car, well, then what are you going to do? So you always have to have that next step with that, is like, is it a family member? Is it some other transportation service that's in the community, to allow people to still have that ability to have mobility? Because if you just want to take their car and not give them another option, they're not going to be as receptive to that intervention. I personally have had families or the patient make the decision every time I've had the conversation. I've never had to call the DOT or call the police on a patient that I believe is unsafe before, because we've been able to work through this discussion and either get the patient to give up their driving rights themselves, which is probably 90% of the time. And about 10% of the time, we've had to do some alterations where family takes the car away, family takes the keys away. I had a family once that took the alternator out of the car because the patient was really like mechanical and they wanted to fix everything, but they couldn't fix that problem. So we solved the problem because they couldn't fix the problem. And so there's just different levels of things you sometimes have to do to get to a decision where we're taking away driving rights, but we're trying to do it in the most amicable way that we can.
Makes sense. That's a great tool, that legacy Clete. That's I wrote it down. I mean,
Yeah, nobody wants that to be, the thing that
you're right. I mean, that's you get away from putting them on the defensive about what their skill level is, and you transition it to their impact on other people. That's brilliant, quite honestly. So, Lindsay, did you have anything to add on driving and aging services?
I guess I would just reiterate that you're not alone when you are a family member and you're thinking about your loved one being safe on the road. We run into that a lot where people are concerned and they don't know how to have that conversation. And it typically isn't just one huge breakout conversation. Having multiple conversations leading up to that is very common and it's hard. And so don't be afraid to reach out to your family doc, to one of us here at Aging Services when you're approaching those situations, because you're not alone and it's hard.
Well, Dr. Younger, always pleasure to have you. You're like a veteran.
Yeah.
I need to check. I think you might have the most appearances on the podcast.
I think we've done 5, right?
Yeah, I think
we've done 5.
I think Abramson might be a close second, but we're going to look into that and see that you get a lifetime supply of rice-a-roni, the San Francisco treat. Lindsay, you're not old enough to remember the game shows that used to be on, but and Lindsay, thank you for joining me today. Once again, this is Dr. Clete Younger, medical director for St. Luke's Living Center, and Lindsay, and Clete, that totally minimizes all the stuff that you do. Just to say medical director of Living Center, because you're hospice, you're an active primary care physician, you help supervise and lead the A&P post-hospitalization team. So I think we need to get a bigger title, at least a footnote, maybe in the podcast.
It's family medicine. We do everything, right?
You do, and you do it well. You really do it well. And Lindsay, thank you for coming. This is Lindsay Glynn, Executive Director of AbbeHealth Aging Services, and she'll now remember why it's AbbeHealth and where that perpetuate that legend. For more information on skilled nursing services provided at UnityPoint Health Cedar Rapids, call 319-366-8714. And for more information about Aging Health Service, Abbe Aging Health Services, visit unitypoint.org/aging services. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.